Hey everyone, welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Today's episode is going to be on mechanical ventilation, specifically though terminology and concepts. For those of you who've been around this channel, you know that we've done a whole bunch of videos on mechanical ventilation. All of them will be linked in our mechanical ventilation playlist in the description. But we realized we never kind of did just a comprehensive overview of terminology and concepts. So that's what we're going to dive into in this video. We're going to start with basic concepts, literally what's a ventilator, positive pressure ventilation, PEEP, respiratory rate, tidal volume, all that good stuff. We'll then go into more advanced topics like different mechanical ventilation modes. We'll talk about alarms, scalars, and loops. We'll talk about more advanced topics like driving pressure. We'll talk about some of the more advanced ventilator settings like I to E ratios and flow rate and all that jazz. So a lot of good stuff packed into here. As an FYI, this is never intended to be acted upon as medical advice. Stick around to the end of the episode for the full disclaimer if you have an interest in that. Again, shameless plug, this study guide as well as practice questions will be on our Patreon page, which will be listed in the video description if you want access to any of that stuff. We also have a weekly newsletter, and you can see this both in YouTube form or listen to it in podcast form. So no more shameless plugs. Let's dive into the concept today. So mechanical ventilation, terminology, and concepts. Starting with just basic concepts. So a ventilator, what is a ventilator? I think all of us inherently know what that might mean, but to spell it out, a ventilator is the actual machine that is delivering the gas to the lungs, and it's under positive pressure. And this is a machine that isn't ever intended to fix the lungs. It's intended to give them time to heal from whatever their primary kind of injury mechanism is. So there's all that stuff with COVID about ventilators kill people, et cetera, but a ventilator is not meant to heal someone. A ventilator is we have no other option. You are going to die without this machine to keep you alive. And by putting you on this machine, we hope that it provides you with enough time to heal from your underlying illness. Positive pressure ventilation is a concept where gas is being delivered to the lungs while under pressure. Okay, positive pressure ventilation. We're ventilating the lungs under pressure. This can be a BiPAP or CPAP mask. You have a sealed mask on the face that then provides gas to the lungs under a certain pressure. In positive pressure ventilation modes, exhalation usually occurs passively. Okay, think about that. Exhalation occurs passively. So in all these modes, you provide an inspiratory pressure. Sometimes you set the inspiratory pressure. We'll talk more about that. Sometimes you set a tidal volume, but that volume when it's being pushed into the lungs generates a pressure. But all the exhalation that occurs happens passively. All right, tidal volume. The tidal volume is the actual cc's of air that is being delivered with each breath. It's usually abbreviated TV. So it's the volume of gas delivered with each breath. And on a ventilator, we're typically targeting 6 to 8 cc's per kg of ideal body weight in adults. The ideal body weight is something you have to calculate based on height. This isn't their actual weight. This is their ideal body weight based on their height. The way we do it is we honestly just pull up MD Calc on the internet and you can calculate the ideal body weight. But there's lots of charts and stuff out there too. So that's the tidal volume. In a volume control mode on a ventilator, you set the tidal volume. Okay. In a pressure control mode, you set an inspiratory pressure, and that inspiratory pressure generates a tidal volume. We'll talk more about that too. The respiratory rate, this is the number of breaths delivered by the ventilator per minute. We set this. This is the respiratory rate. It's breaths per minute. Fraction of inspired oxygen, also known as the FiO2. This is the percent of oxygen in the gas mixture that's being delivered to the patient. This is often what we set to. It goes from 21%, or 0.21, so 21%, also known as 0.21, all the way to 100%. Why is 21% the lowest? Well, that's the FiO2, the fraction of inspired oxygen of just atmospheric air. That's what we're all just breathing right now. So we don't put the oxygen lower than the lowest oxygen you would just breathe if you were breathing on your own. Okay, PEEP, or positive end expiratory pressure. This is an important one, and it's a concept that is not that hard to master, but you do have to just think about it for a minute. So this is the pressure that is maintained in the airways at the end of expiration. The pressure maintained in the airways at the end of expiration. So what this means is that even when a person is expiring, The PEEP is the pressure that is always there. Now, when they get an inspiration, there's usually more pressure. But even at the end of expiration, the PEEP is always there. And we set this, the quote unquote lowest PEEP that people use is 5, but you can set a PEEP of what you like. And the goal here is that it prevents alveolar collapse. All right, because if the PEEP went to 0, if there was no pressure and you let a patient fully exhale all of the air out of their lungs, well, whatever their exhalation volume is, we should say, and there's no pressure left, those alveoli would collapse. And then when you push a breath back in, those alveoli will be kind of ripped back open, and it can lead to something called atelectatrauma. Atelectasis being that collapse of the lungs, atelectatrauma being what can happen if you have too much alveolar collapse and reinflation, collapse, reinflation, collapse, reinflation. All right, the peak inspiratory pressure. We actually have a dedicated video on peak inspiratory pressure and plateau pressure, so this is not going to be a deep dive like that was. Again, check out the playlist. Sorry, our allergies are getting us today, but check out the plays for a detailed dive. But the peak inspiratory pressure is essentially the highest pressure achieved during inspiration. So this is often shown on the ventilator with each breath if you're in a volume control mode, okay? Because the volume control mode, you set the tidal volume, the TV, and then when that tidal volume is pushed in, it generates a peak inspiratory pressure. And the ventilator usually shows this number. And this is usually a reflection of both airway resistance and lung and chest wall compliance, right? It's the pressure generated when you're pushing a breath in, and it's going through those airways. So the airway resistance generates a pressure. Then it gets to the alveoli, right? And the alveoli have to expand, and that requires pressure too. So, it is the sum of the airway resistance and the alveolar pressure. When you pressure breath in through a trachea, it goes into the bronchi, into smaller bronchioles, and it inflates the lung itself. Whereas the plateau pressure is actually the pressure measured during an inspiratory pause. So there is no flow. That's a really important concept. There's no flow. So the plateau pressure, you actually hit a button on the ventilator, again, assuming you're in a volume control mode, and it's an inspiratory hold is what it is called, or an inspiratory pause. So you hit the inspiratory hold, and it essentially the ventilator gives a breath, and then it holds. There's no flow of air. The whole system's kind of frozen. The air that is in the lung stays there, and it records the pressure generated just by having that air in the lungs, okay? And that's an estimation of alveolar pressure or lung compliance, which makes sense, right? Because airway resistance is no longer part of the equation because the breath is just being held. There's no flow of air going through the airways at the time. So it's really just what the alveoli, as they're kind of trying to collapse down on the air that's already there, the pressure that's being generated. So this is an alveolar lung compliance pressure compared to that peak inspiratory pressure, right? Which is where you push that breath in and it has to go through the airways, which generates resistance, and expand the alveoli, which generates pressure. All right, compliance. This is going to be the last kind of piece of terminology in the introductory section here. And compliance, we've used it a lot. We keep saying lung compliance, lung and chest wall compliance. Well, what is compliance? Compliance is the change in volume per change in pressure. All right, the delta V over the delta P. So change in volume over change in pressure. And that makes sense, right? Because the compliance is, for lack of a medical term, kind of how stretchy, how compliant those lungs are. You can think of like the classical, just out in the world definition of compliance. It's how easy it is for those alveoli to expand. So if it's easy to make them expand, it should not, when you expand them by increasing the volume in them, it should not generate a large pressure. So the compliance should be higher. They should be more compliant, right? The denominator is lower and the numerator is higher. So a higher compliance means kind of, stretchy or easier to inflate without generation of much pressure, that change in volume over that change in pressure. There are two different types of compliance talked about. There's static compliance and dynamic compliance. Static compliance is measured at zero flow. Okay, zero flow. And the static compliance is essentially the tidal volume divided by the plateau pressure minus the PEEP. And if you've watched all of our lectures, and this is an advanced topic, right? If this is kind of above the level, just ignore this. We'll get back into the bread and butter. But the plateau pressure minus the PEEP is this thing called the driving pressure, which we've talked about before. So tidal volume divided by that is static compliance. There's no flow. And because there's no flow, that's why you take the plateau pressure, right? Because as we said, the plateau pressure is measured at an inspiratory hold with no flow. Okay. Whereas dynamic compliance is measured during airflow. So instead of the plateau pressure, you take the peak pressure. So that equation is the tidal volume divided by the peak pressure minus the PEEP. But these are more complex equations. The concept is compliance is related to the change in volume divided by the change in pressure. All right, that's a more important equation to remember rather than kind of static and dynamic compliance. That starts to go down the road of complexity there. All right, what about common ventilator modes? So here we'll break it up into kind of mode, name, controlled variable, and description. Sorry, grabbed a little drink. So starting with this, these two that are CMV and AC. So CMV is continuous mandatory and AC is assist control. And we really only use, at least traditionally, someone correct me in the comments if you're using continuous mandatory often, but we're really using assist control mostly. And assist control means that a patient can trigger their own breaths. Okay, so when a patient is in volume control or pressure control, we don't say this often, but it's usually assist control volume control or assist control pressure control, also known as ACVC or ACPC. And that just means if it was continuous mandatory, the ventilator would just give them the breaths that we set the respiratory rate at. But assist control allows the patient to trigger those breaths, which helps with ventilator desynchrony, right? If a patient can say, hey, I'd like to take a breath now, and then the ventilator says, okay, I'll help you with that breath, and it assists them, that's going to be much better than the ventilator just being like, I don't care if you want to take a breath or not. I'm going to push a breath in and push a breath in and push a breath in. I'm just at my own pace. So these days, I think assist control is the primary mode we all use, and it could be assist volume control or assist pressure control. All right. And as we just said, it delivers a set tidal volume or a set pressure at the respiratory rate, but the patient can trigger the breath if they're able to. Now, the ventilator will still give them a breath. If I set the respiratory rate at 20, right, and I'm in assist control mode, if the patient takes 20 breaths, the ventilator will just let them trigger all 20 breaths. But if the patient only takes 10 breaths, the ventilator will give them an additional 10 breaths to make the 20 that we set. All right, SIMV is called Synchronized Intermittent Mandatory Ventilation. This is not widely used anymore. I personally, I don't really ever use it actually. But what this is it's a mode where the ventilator delivers the mandatory breaths that you've set, and it can synchronize those to patient effort. But if the patient wants to take additional breaths, let's say I set the respiratory rate at 14. Okay, for 14 breaths, the ventilator will assist that patient. But if the patient wants to take 24 breaths, there will be 10 breaths that the ventilator will not assist the patient in. That's just the patient tries to suck air through the endotracheal tube. And this used to be used as kind of a weaning strategy because you could decrease the respiratory rate, which would then mean the patient had to take more of their own breaths. But it's not widely used anymore. My humble opinion is that the evidence doesn't suggest it's helpful. But yes, it is something that you could set, and you will still hear it. And some of the folks out there who have been doing this a lot longer than me maybe used it more or still use it more because they're comfortable with it, but not part of my practice. But yes, this is where the ventilator will sync to the patient's effort for your set number of breaths that you set on the ventilator, the set respiratory rate. But any breaths beyond that, the patient has to take on their own. Whereas something like assist control, even if I set that respiratory rate at 20, if the patient takes 30 breaths, the ventilator will assist them for all 30 breaths. So if I set that, tidal volume at 500, and the patient wants to take 30 breaths, for all 30 breaths, the ventilator will assist them and try to give them a tidal volume of 500 for all 30 of those breaths. Whereas again, in SIMV, if I set that ventilator at 20 and the patient wants to take 30 breaths, for 10 of those breaths, the ventilator will not assist them at all. The patient will just kind of suck in air as much as they're able to. PSV, or pressure support ventilation. This is where the patient has to trigger all of their own breaths. This is a mode we often use when we're trying to see if a patient can be liberated from the ventilator or extubated. You'll put them on a pressure support trial. Now, there is usually an inspiratory pressure, and this is an important concept. It's a little tricky, and again, this is just an introduction to the nomenclature. But on a pressure support trial, you will have a PEEP. Remember, a PEEP is a positive end expiratory pressure, and that PEEP is typically 5. But you also will have a set inspiratory pressure. And it's usually, 5 above the PEEP, or you can use 7. You can set it to whatever you want to. And this is a little extra inspiratory pressure the ventilator will give when the patient takes a breath. And the thought here is that it's just enough pressure to help get past the airway resistance of the endotracheal tube, right? The endotracheal tube is, for all intents and purposes, a big straw. And a patient trying to suck air in and out of that straw is going to meet resistance. Try breathing in and out of a straw, right? It's hard to do. So the inspiratory pressure that you set is just supposed to give a little extra pressure to overcome that resistance. But all the breaths in pressure support mode are triggered by the patient. The ventilator will not give them any breaths. All right, CPAP is continuous positive airway pressure. This is essentially spontaneous breathing, but you just set a PEEP. People use CPAPs at home and things. This is just an end expiratory pressure that is set. Everything else the patient is doing themselves. All right, APRV. This is really complex. We have a whole a whole episode we're putting out on APRV. It will be already out by the time this episode debuts. We suggest you just check out that episode because this is going to be too hard to explain quickly. It stands for airway pressure release ventilation, and it's essentially a time-controlled high pressure with intermittent pressure releases to facilitate ventilation. But that probably doesn't make sense when I just speak it that way. So definitely check out that episode if you have an interest. All right, what about key ventilator settings and parameters? So key ventilator settings and parameters, there's a couple things that are important to note here. The biggest one is the I to E ratio. This is the inspiratory to expiratory ratio. And if we think about this, this is essentially the amount of time a patient has to inspire on the ventilator and expire. Because we're setting a respiratory rate, and that respiratory rate has to be given within a minute. That's what we're saying. So if I set a respiratory rate of 30, that means that the ventilator has to give 30 breaths in each minute, which means on average, that breath's only going to last about 2 seconds each. So the I to E ratio is, okay, if I can only give a breath in 2 seconds, how much time is going to be inspiration versus expiration for that 2 seconds? And a normal I to E ratio, if you just think about yourself breathing, we spend a little more time expiring than we do inspiring, because inspiration is active. Even spontaneous inspiration, our diaphragms contract, and that causes inspiration, whereas expiration, our diaphragms just relax, and that expires. On the ventilator, though, inspiration is active in the sense that we're pushing that breath in. Expiration on the ventilator is essentially we stop pushing that breath in, and the patient just exhales at whatever pace they do. So normal IDE ratio is something around 1 to 2. So that means, let's make this easier math. If I set a respiratory rate of 20, that means let's give 20 breaths in a minute, which means there's about 3 seconds per breath. So if I have an IDE 1 to 2, it's going to be 1 second in inspiration and 2 seconds for expiration. And this gets really important for things like auto peeping or breath stacking. Again, we have an episode on that. We won't dive into it here, but you can adjust this I to E. You can increase the amount of time they're in expiration if they have something like obstructive lung disease, where you have a much more prolonged expiratory phase. All right, flow rate. So flow rate is the speed in which gas is delivered during inspiration. The units are often liters per minute. And this matters because it can be related to ventilator synchrony. Patients sometimes want more flow than they're able to get on the ventilator, because the ventilator says, okay, I'm just going to give this much flow of gas over this time frame. But if the patient is saying, like, taking these big, robust breaths and they want more flow, it can lead to ventilator desynchrony, which can cause issues. So sometimes they need more flow than the ventilator will give them. And flow rate is a bigger problem in volume control modes. Because in volume control modes, we're saying we want a certain tidal volume, right? A certain milliliters of volume given with each breath. And we're saying we want a certain number of breaths over a minute. And each breath then represents a certain amount of time. And that drives the flow rate in volume control. So if I just, let's see if we do easy math. If I set the tidal volume at 300 milliliters, and I set the respiratory rate at 20, which means there's about 3 seconds per breath, that's going to be, let's see, about 100 milliliters. Wait, but this is just for inspiratory, right? So 3 seconds per breath. Let's say the IDE is 1 to 2, which means there'll be 1 second of inspiration for every 2 seconds of expiration. So that's going to be 300 milliliters per second is the flow rate. All right. And if a patient wants more than that, it can lead to ventilator desynchrony. So in volume control, flow rate can be something really important to think about if you're seeing flow starvation. We actually have talked about that in episode 2 on desynchrony. Again, check out that playlist. Inspiratory pause or inspiratory hold. This is how you get the plateau pressure. It's a button on the ventilator. It essentially gives a breath and then pauses, so there's no flow. We talked about that already. Trigger sensitivity. This is something people don't think about all the time, but the ventilator is actually set to be sensitive to a certain degree for when a patient wants to take a breath. I feel like I explained that poorly. The ventilator essentially has a threshold. It can either be a pressure threshold or a flow threshold, because we said most of the time now we're using assist control. An assist control supports patient-triggered breaths. But what does triggered mean? How does the ventilator know the patient is trying to take a breath? And that's where trigger sensitivity comes in. There's a certain threshold. The patient has to mobilize a certain amount of pressure or flow that the ventilator detects that then triggers the ventilator to say, oh, okay, you want to take a breath. Let me give you the tidal volume of 500 that the person set on the ventilator. And this can be adjusted. There's a lot of complexities here. This can be important for breath stacking and auto PEEP and all sorts of stuff. But some patients need changes in their trigger sensitivity to help with ventilator synchrony. All right, rise time. This is the rate or time it takes the ventilator to reach a set inspiratory pressure in a pressure targeted mode. So this would be in pressure control. The rise time is essentially how fast that ventilator gets to the inspiratory pressure that you set. So this is not relevant for volume control modes, but this is something that's relevant for pressure control modes. All right. Monitoring and alarms. We're going to fly through this because waveforms, there's 3 waveforms we talk about. We have episodes on all 3 of these waveforms. The one that's usually kind of on the top is the pressure versus time. The one in the middle is usually flow versus time, and the one on the bottom is volume versus time. If we're in volume control mode, pressure versus time usually looks something like this. Right, this is what the scalar usually looks like. Flow versus time usually looks something like this. Oop, hopefully we didn't mess that up. Volume versus time usually looks something like this. Wow, these are really bad scalars, but check out our other videos to look more at these. There's a lot of rich data you can get from these waveforms or scalars, but they're very complex too, and they're different between pressure control and volume control. The scalars look totally different, which is something that you should note. Alarm types, high pressure and low pressure alarms happen not inconsistently. High pressure alarms, which essentially the peak pressure is too high. This can be from secretions, bronchospasm, decreased lung compliance. Low pressure alarm, this is usually a disconnection or a leak. This can be really important to note. Sometimes the cuff on the endotracheal tube is ruptured. Sometimes the endotracheal tube came off the connector to the ventilator. So low pressure alarms are things where you should trace the circuit really well, from where it plugs into the ventilator all the way to where it enters the patient's trachea. High or low tidal volume alarms come on all the time. Sometimes it's a circuit issue if there was a leak. Sometimes it is a patient issue. And then apnea is essentially when the patient's not taking any breaths. You can get an apnea alarm. Advanced terminology, I think we're getting into close to the end. There's, advanced terminology, then troubleshooting. Advanced terminology starts with driving pressure. We have a whole episode on driving pressure as well. This is the plateau pressure minus the PEEP, okay? And it can be an indicator of kind of lung alveoli distension. The goal is to keep it less than 15. Auto PEEP or intrinsic PEEP or breath stacking are all concepts that describe or give a name to the retention of air at the end of expiration. Again, this is an easy topic that sounds confusing when you just hear it for the first time, but when a patient breathes in, if they breathe in 500 cc's of tidal volume, but for whatever reason, they're only able to expire 450 cc's before the ventilator gives them the next breath. That means there's 50 cc's left in their lungs. Then the ventilator gives them a breath, right? So now they got 550 cc's, even though you only wanted them to get 500. They breathe out again. They can only breathe out 450 cc's. Now they have 100 cc's left in the lungs. Again, the ventilator gives them another 500, so on and so forth. So this is auto PEEP or breath stacking. We see this a lot in obstructive lung disease when patients need a lot more time to exhale. And we, not to be a broken record, have a couple episodes out on that too, so check it out in that playlist. Permissive hypercapnia. This is the concept where we allow an elevated amount of arterial carbon dioxide, PaCO2, as a way to reduce ventilator-induced lung injury. So in our patients with ARDS, this is something we do. We really want to make sure those patients aren't getting barotrauma, which is where you get kind of overdistension in the alveoli causing damage. So we will drop their tidal volumes lower, 6 cc's, 5 cc's per kg, target a certain plat pressure. We have a whole series on ARDS too, so check that out. But we'll allow them to have some permissive hypercapnia. We won't try to aggressively make their carbon dioxide normal because by doing so, we'll cause more lung damage. So instead, we let the carbon dioxide stay a little high if it means that we can have better control of any injury to their lungs. Recruitment maneuvers, we don't do these very often anymore. This is the idea where you can transiently increase the airway pressure, right? So increase their inspiratory pressure for a certain amount of time to try to recruit collapsed alveoli. There's been some trials on this, and the trials don't show that improves outcomes. It actually increases risk for things like pneumothorax and ventilator-induced lung injury, et cetera, et cetera. Hemodynamic instability was an issue in these studies. So we do not do recruitment maneuvers, at least not typically anymore. Pressure volume loops. This is a loop you can get on the ventilator. We won't talk more about that. It can be helpful with when there's overdistension or collapse of alveoli. Electrical impedance tomography. This is not something that we use, but it can be used to monitor kind of regional lung ventilation. Ventilator-associated lung injury or ventilator-induced lung injury is another way you'll hear people talk about it. And this is injury to the lungs from mechanical ventilation. We got a whole episode on this: barotrauma, volutrauma, atelectotrauma, or biotrauma. And then esophageal pressure monitors. Some shops have an esophageal probe where you can do esophageal pressure monitorings, which can help you understand something called the transpulmonary pressure. Troubleshooting and clinical pearls. I'm going to leave this here in case you want to look at it. This is a little outside of this video, but I wanted to include it here because it helps you understand kind of plateau pressures, PEEPs, auto PEEPs, ventilator desynchrony, how to wean, which are all separate episodes. But for the sake of comprehension, it's here if you want to pause and take a look at it. All right, and the last thing here is we did include a glossary of these abbreviations so that you have them. Again, this whole thing will be in study guide version on our Patreon page. But this is a nice glossary of abbreviations if you work in the clinical arena to give you a reminder of these different things. Hopefully that was helpful. Let us know what thoughts, comments, questions you have. We'd love for you to subscribe, follow along. Again, check out that Patreon page. It'll have all the study guides, practice questions, and a ton of other good stuff. And then we have a weekly newsletter too. Either way, stay well, keep learning. We'll see you next time. Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.